Let's get started on today's case where we have a little bit of trauma. We have a young male who's been involved in a significant car accident. He's been ejected from the vehicle right through the windshield. He's found lying on the tarmac. GCS low at the scene. He gets intubated in the scene and brought into your cells. Fairly unresponsive when he arrives. He gets brought to a CT scanner. He's got a horrible crack caved in skull at the side, and on the brain windows he's got blood, and he's got a tight looking brain in there. Ventricles have disappeared. He's certainly got a huge hematoma sitting externally as well. Okay, so this is a guy who's in trouble. Okay, he's got a severe traumatic brain injury. You get him back from the CT scanner and you're doing all the usual neuro observations and you're checking his pupils, and you notice when you get back that he's blown a pupil on the right hand side, so he's got a dilated pupil. So this is the thing that we're looking for when we're doing neuro observations. So what's happened here? Well, hopefully this is nice and easy. I mean, this guy's coning. He's having a brain herniation event. He's squeezing his brain like toothpaste out of a tube through the foramen magnum. As the pressure's gone up in the skull, it has to squeeze out somewhere. It squeezed through the brainstem, and that's the end of things, isn't it? Okay, well, brain herniation is a little bit more complicated than that. There's a few more subtleties to it that might be useful to you, so we're going to try and we're going to run through those. Okay, there are three main types to talk about. Okay, there are lots of others described, but three that are probably a wee bit more relevant and common. The first one we're going to talk about is subfalcine herniation. What we mean by this, the falcine, it refers to the falx, the piece of dura mater underneath, and it's the brain herniating underneath the falx that forms subfalcine herniation. That's the first one. The second type that you'll hear is what I'm going to call transtentorial, because I think that's a bit more descriptive, where you get herniation across the tentorium cerebelli. Now sometimes it's called uncal herniation because a bit of the brain that does the herniation is called the uncus, but I think transtentorial is a bit more useful to let you know where the actual problem is. That's where you get the really famous signs, things like the pupil and so on, but we'll get to that in a second. And then thirdly, the other important one is tonsillar herniation, and what we're talking about here is the tonsils of the cerebellum squeezing through the foramen magnum, and that tends to be the final point of all these brain herniation syndromes. Okay, so let's start with subfalcine. Okay, we've already mentioned that the falx that we're referring to here is the sheet of dura mater. Okay, we talked a little bit about it last time when we talked about the sagittal sinuses. Okay, the superior and the inferior one. This is a fold of thick dura mater that separates the right and the left hemispheres. You can see it marked on there in red. It's running all the way from the front to the back, separating the two hemispheres. On the MRI that we have here, I'll see if I can run through it. You can see it quite nicely in this one. And this is a grossly abnormal MRI for lots of reasons, and we're not going to go into. Now, if we start at the anterior part, can you see this shiny piece coming into view now? If I run that a bit further, you'll see it running all the way across the back. So that shiny sheet of material lying right in the midline, separating the two hemispheres, is the falx that we're referring to, the falx cerebri. And when the brain herniates, it's usually the cingulate gyrus, a bit of the brain that herniates under the falx, just there. Okay, so as mentioned, the piece of the brain we're interested in is the cingulate gyrus. Don't worry too much about that, it's not that important to you guys. It squeezes underneath the falx cerebri and ends up lying kind of adjacent to the opposite cerebral hemisphere. Okay, so here's an example more usefully and more relevant of what we see is midline shift. So when you see midline shift on a CT scan, particularly where the ventricles have been shifted all the way over to another side, that's, you've got subfalcine herniation. Okay, so the cingulate gyrus has looped underneath the falx cerebri and it's brought one of the lateral ventricles with it. Okay, tucked deep to the cortex there. So that's what you're seeing when you see a lot of midline shift. You're actually seeing subfalcine herniation. Okay. So you can see it nice and clearly in this one. Here we have nice midline, lateral ventricle, okay. Here we have the two lateral ventricles both sitting left of the midline. Okay, everything shifted well over to the left. Well, that's all very interesting, but I mean, does any of this really matter then? I mean, we see midline shift all the time. If that's what we mean by herniation, is it important? Well, there are a few things that probably are relevant to it. If you get everything shifted over to the left-hand side, like we have in the CT and the right here, okay, if this all shifts over to the left, you've got to remember that there's some traction on the circle of Willis. This is our famous circle of Willis. So if you get all this pushed over to one side, you're going to get pressure and traction on the circle of Willis. You might get one of the arteries pinched off. And the classic one that tends to get pinched off is the anterior cerebral artery. Okay, so not only have you now got a brain injury syndrome, you also may end up with a stroke syndrome out of this as well. Okay, so these things can happen. It's not inevitable that when you get a subfal sign you get pinching of your anterior cerebral, but it's something that you want to think about if you've got a lot of midline shift. It is important to say, I mean, midline shift doesn't mean the end of the world. It's not quite the same as the tonsillar herniation that we talked about. We see patients with midline shift all the time. This CT scan is actually a chap with this is a large chronic subdural, okay, a couple of weeks old subdural hemorrhage, which has caused midline shift over the left-hand side. This guy was confused, but he was able to talk to you, he was conscious. So midline shift doesn't imply a comatose, unconscious patient, okay, but it certainly can progress to the other forms of herniation that we worry about. Okay, let's talk about transtentorial, because this is probably this is where the money is for us. This is where we're going to pick up the signs and maybe even do something about it. There's usually a few clinical signs that'll be a giveaway that'll help us to actually intervene and do something. One thing I should note as well is diagrams can get across. There can be two-way traffic. You can get herniation of cerebellum into above the tentorium cerebelli, but most of the time it's going down the way. So this tentorium we're referring to is the tentorium cerebelli that covers over the posterior cranial fossa. Okay, so it's marked on there. It runs all the way from the occipital bone all the way across, and you have the brainstem tucked into this notch within the tentorium cerebelli. Okay, so it separates cerebellum underneath, cerebral hemispheres on top, and then this big notch in the middle for where the brainstem fits through. Again, same thing, just marked out just actually on the skull. Posterior cranial fossa with anterior middle posterior cranial fossa. Okay, tentorium stretches across there, leaves just enough room for brainstem to squeeze through the foramen magnum. Let's have a look at an MRI scan. It's fairly obvious in this one that we have. Again, this is this grossly abnormal scan I've been using a few times. I just want to see the tent-shaped structure. See the shiny white bit there? That tent-shaped structure, okay? With the cerebellum underneath. So we have the cerebral hemispheres resting on top of the cerebellum. And if we move that forward anteriorly, we should see, so see here, this is the notch that we saw in the last one with brainstem passing through it, okay? So when we get herniation, we're going to have brain slipping through alongside the brainstem, going through the notch in the tentorium cerebelli. Okay, the signs, why do we see the signs that we see in a tentorial herniation? Okay, it's to do with the structures that are being pressed on. When you get transtentorial herniation and the cerebral hemisphere is trying to squeeze through this notch, the things it's going to press on, and the thing that we're looking for is the oculomotor nerve, the third cranial nerve, okay, the one that does most of the eye movements and is involved in pupillary constriction as well. Okay, so if you put pressure on the oculomotor nerve, if you squeeze brain down beside that, between the midbrain and the pons, you're going to put pressure on the oculomotor nerve. You're going to lose the constriction function of the oculomotor nerve, and your pupil will dilate as a result. Okay. Okay, let's show you it on an MRI scan. Yeah, this is maybe a reasonable example. So see this large mass effect. We've got midline shift over here. This is the uncus of the brain that is pressing just on the midbrain here and the pons here. Here we have midbrain, here we have pons, and we've got the oculomotor nerve just in front of that. So you're going to get pressure on the oculomotor nerve just at this point. Now, it's also worth noting that you'll get pupillary involvement in a transtentorial herniation before you get motor involvement. There's two real big functions of the third cranial nerve. One is to constrict the pupil, that's the parasympathetic part of it. The other is the motor aspect of it. It does all your eye movements, okay? So you're likely to get the pupil involvement before you get the classic down and out pupil. The theory behind all that is that you've got the parasympathetic fibres lying peripherally in the nerve on the outer aspect of the nerve, so they get affected by mass lesions first, whereas the actual somatic motor fibres from moving the eye lie more centrally. So you'll get pupil involvement before you get muscle involvement. Same thing would apply in a posterior circulation, posterior communicating aneurysm. That would be the same sign you get. And in fact, if you get a down and out pupil without pupillary dilation, it's more likely to be a neuropathy of the actual nerve than a mass lesion on it. Anyway, we need to go on a bit further. What other signs do we get from a transtentorial herniation? Well, the other signs we get are usually motor signs. Now, these can be a bit variable, and depending what you read, they're not entirely straightforward. You can get ipsilateral with the lesion, you can get contralateral signs, or you can get bilateral signs. I mean, all of those have reasonable anatomic explanations. So the pupil signs are probably more useful as a localizing sign. But that's, if we look at our MRI here, this is our MRI with the pressure coming down, okay, in the midbrain, and I've just put a little image of the midbrain just on top of it. We're looking at the anterior midbrain, this is thalamus, and this is midbrain, pons, medulla, just here marked out. So the thing that gets pinched with this is you're going to get pressure on the corticospinal tracts, okay, those are the descending motor fibers carrying all the motor function down to our limbs. These will run down with the corticospinal tracts, okay, and then they will cross over at the lower medulla, an area called the pyramids, if you can remember that from med school all the way back. So if you can imagine, if you're getting pressure on this corticospinal tract, you're getting dysfunction of that, you will then have eventually a contralateral hemiparesis. So if all the pressure is coming from this side, pressure on the midbrain here, on the corticospinal tracts, you're going to result in a contralateral hemiparesis, okay. Now, you can get an ipsilateral one, because you can imagine that this part of it, if you're shoving everything across from this side to this side, you can actually cause pressure of the tentorium on this part of the corticospinal tract as well. Sometimes it's called a false localizing sign when you see an ipsilateral hemiplegia with the side of the lesion. So these things are a wee bit, I mean, it's doubtful to know how much of this is any useful clinically, but certainly the pupil is going to be a little bit more useful to us. Finally, we're going to have tonsillar herniation. Okay, now this is a big one. This is what we describe as coning. If this goes off in a bad way, then you likely end up dead, or if you're on a ventilator, then this is often one of your final steps towards brain death, and you're an organ donor. So this is important. This is kind of a big deal. So here's a bit of a learning point for this that we'll start with. You've got to be careful in the posterior cranial fossa. This is somewhere you can run out of space real fast.
Forward. Stay alert, we could run out of space real fast.
Okay, so a little bit like invading the Death Star in Return of the Jedi, the posterior cranial fossa is a tight little space. You get some swelling and some blood in there, you can get death pretty quick. This is one of the places where if you have a problem, neurosurgeons actually are much more likely to intervene. You get a hematoma in the cerebellum and the posterior cranial fossa, that's more of an indication for neurosurgery. Okay, they'll actually intervene on that given how tight the space is. Now, part of the reason it's so tight, we've already noted you've got this posterior cranial fossa is squeezed in between the tentorium, okay, and the base of the skull. Okay, so there's not a great deal of space in there. Just to highlight it again, okay, tentorium will run separating the cerebral hemispheres. In the notch at the front, you'll have the brainstem running through it, and then you've got the base of the occiput and the foramen magnum just in there. So not a great deal of space if you get a lot of swelling. Okay, so what is the tonsil that we're talking about that's actually doing the herniating? This is a sagittal section through the brainstem and the cerebellum. We have midbrain would be here, pons here, medulla down here, and then we're just through really the centre of the cerebellum. The cerebellar tonsil is this section of it, okay? The medial and the inferior section of the cerebellum is referred to as the tonsil. So if you get herniation of that squeezes through, it's normally just sitting above the foramen magnum, that squeezes through and presses on the medulla. Okay, and the medulla contains important cardiac and respiratory centres. You cause those to dysfunction, and all of a sudden you lose your cardiac tone, you lose your cardiac output, and you lose your respiratory drive. So you can have a dead patient very, very quickly from that. On the right, we have a little example on an MRI of a cerebellar herniation. I've just marked it on there. So if this is the level of the foramen magnum, okay, we have herniation of the cerebellar tonsils through onto the medulla, okay, and medulla then becomes spinal cord as it passes through. So that causes certainly the pressure on the centres is a big problem, but you're also going to, I mean, if you think about all these things, you're also going to get lots of vascular issues as well. Remember, your vertebral arteries have to squeeze in through the foramen magnum as well, so you can sometimes get ischemia, you can sometimes actually get hemorrhage from this as well. So that is why tonsillar herniation is such a big deal. Now, the other thing that you will see it with is Chiari malformation. Now, you might see this in MRI scan reports and various other things. Not all tonsillar herniation is immediately fatal. People with the Chiari malformation are born with their cerebellar tonsils herniated through the foramen magnum. Now that can cause various different problems, and that's a really complicated syndrome I'm not going to get into in the slightest. But just be aware that these people have tonsillar herniation, but they're sitting wide awake and talking to you. And this is an example of tonsillar herniation on somebody with a Chiari malformation. Okay. So let's just run through these three, so hopefully they'll stick in your head. We have three main forms of brain herniation that we're interested in. The first one's going to be the subfalcine, okay, where we herniate brain underneath the falx cerebri, usually the cingulate gyrus, squeezes over from, in this case, right to left. Be wary of pinching off the anterior cerebral artery and getting a stroke-like syndrome from that. And we see this on CT scans as midline shift. Second one you're going to talk about is the transtentorial herniation, where you get the bit of the brain called the uncus, tends to go down the ways rather than cerebellum going up the ways. This is where you get your traction and pressure on the third cranial nerve. This is where you'll get ipsilateral pupillary dilation. So that's a sign that we're looking for. If you've got a transtentorial herniation, you want to do something about that quickly, lower the pressure, get a neurosurgeon involved. Otherwise you're going to progress towards the third one, the tonsillar herniation. Now there are motor signs associated with transtentorial herniation, but they're a little bit, let's just say they're not that dependable and they're a bit variable. Last one, tonsillar herniation, where we get cerebellar tonsils, which herniate through the foramen magnum, causing pressure on the cardiac respiratory centers in the medulla, frequently resulting in death very shortly afterwards. Okay, so these are your three main brain herniation syndromes that you want to be thinking about when you're looking after severely head injured patients, and hopefully that's a bit of use to you.